All right, we should be live. We're just about a minute early as we're waiting for everyone to log on, but I wanted to welcome everyone to today's VETgirl YouTube live webinar. Really excited to have Dr. Tammy Grubb here with us today. We're going to be talking about some pain management, and she is, if you've been on our VETgirl platform before, you know how amazing Dr. Grubb is. If you've been on our YouTube lives before, you know how we start, how we roll in the beginning of our sessions. My name is Garrett Pachtinger. I'm the co-founder of VETgirl along with Justine and a critical care specialist. And I will tell you, I am logging in as I look out of my window from pretty sunny Pennsylvania. We've had some good weather the past couple of days, although I expect some thunderstorms tonight, but I'm going to enjoy the weather. As you all know, please, as we're talking, we love to know where you're logging in from around the country or around the world. So please go ahead and type that in where you're logging in from. Justine, what about you? Where are you logging in from today?
I'm in sunny 85-degree, beautiful Minnesota, and really excited. We're actually going to be hosting VETgirl U 2022 in, gosh, just about 6 weeks in the Twin Cities. So if you guys haven't signed up, you definitely want to check that out. But beautiful, hot, humid weather in Minnesota right now.
Yeah, definitely don't want FOMO. For those of you that were with us in our 2018 event, it was a super, super fun time. We've taken it up a couple of notches. It'll even be more fun. So don't have that FOMO and hear from all your friends and colleagues how amazing VETgirl U was and what awesome swag you got. So keep typing that in. We have Maureen from Pittsburgh, Savannah from Detroit Lakes, Minnesota. We have Janice from Oregon. So keep going. Oh, we have Jin Kuo, I hope I didn't pronounce that wrong, from Taiwan. Welcome. But Dr. Grubb, where are you logging in from?
Wow, this is so cool where everybody's from. How exciting. I am also sunny, but not so hot. Uniontown, Washington, which no one would know where that is. It is just south of Pullman, where Washington State University is. So we're right on the Washington, Oregon, Idaho border. So I can be in 3 states within like 10 minutes.
Well, Dr. Grubb, Julia Vanderford, one of your previous students who's living in Mississippi now, wrote in to say hello. She's on with us today. We have Candace from Cali, Siri from St. Paul, Minnesota. So keep going ahead and typing in. We're waiting for our friends from Portugal and all over the world to log in with us. But as we go ahead, let's get started. Keep typing into the question screener. Des Moines, Iowa, hot and humid. Oh, boy. The humidity is something totally different. We have from Qatar. Welcome. See, I told you, Dr. Grubb, all over the world. But let's go ahead and get started as you guys are typing in and where you're logging in from. And trust me, we love this. We love this. So, yeah, we're going to be talking with Dr. Grubb about keep moving down the path of effective pain management, the importance of longer duration drugs. So stay tuned for that. We're going to be getting into this in just one second, but a little bit of housekeeping. First of all, for those of you that have been with us before, when we've had the fortune of partnering with an amazing educational partner. Today, it's Elanco. We're happy to offer this completely complimentary race-approved event free to all the world. So again, thank you to Elanco for getting Dr. Grubb with us and talking about this really important topic today. Super important now. As I just said, this is live, this is interactive, this is race-approved. So how are you going to get your CE certificate? There's one of 2 ways to fill out the form to let us know you were here live. You can either take your fancy smartphone and take a little sort of screenshot, or go ahead and use that camera function on your phone with that QR code. If that camera is on that QR code, it'll bring up a link. Click on that. It'll bring you to the form. Otherwise, Justine has just put it in the question screener, tinyurl.com/VG, and then today's date, which is 07/12/22. If you type that into any browser, it'll take you to that same form. You don't have to do it right now this second. We're going to leave this form open until 1 p.m. Eastern, which is 30 minutes after the live session. But this is the only way to get your live and interactive race-approved certificate. Either use your fancy smartphone and that QR code, or type that into the question screener, and Justine just put another link in that question screener for us. We'll remind you of that one more time at the end of the session, but this is how we know you are here live with us. And a little housekeeping or pro tip for YouTube, that bottom right icon on your YouTube screen, I know there's small thumbnails to begin with. If you click on that, it'll make it the entire window, so you get to see Dr. Grubb's slides nice and big. Last couple things. Again, one, this is live and interactive. There's no quiz. Just make sure you fill out that form to get your CE certificate. If you do watch this on our website after the fact, because you're a VETgirl Elite member, yes, there's a short quiz. We hope YouTube Lives are not the only thing you're doing with us. We have a whole host, a multimedia approach to education, whether it's our YouTube Lives like today, our traditional webinars, our how-to videos, our blogs, our podcasts, and don't forget about our certificate programs. Currently, we have, I think, 8 and a 9th coming up with our feline track coming up soon. Those are a value add part of your VETgirl membership. So take a look right at the top of the website. There is a certificate program button. Click on that and you can see all of our active certificates. We created them for you. Please give us feedback. We'd love to know, but we hope you do enjoy them. And then as Justine started talking about, if you haven't signed up for VETgirl U 2022 yet, please do. You're going to miss out on an awesome experience. You get wined and dined, treated as we think you should be treated, amazing lectures, TED-like talks, awesome swag, evening events, get to mingle and interact with colleagues. Trust me, we've done 2 now. This will be our 3rd. Super fun and a worthwhile experience. All right. I know you're not to hear from here. You're here to hear from myself or Justine. We want to hear from Dr. Grubb about pain management and analgesia. So what I'm going to do, Dr. Grubb, is I'm going to drop myself and Justine out of this presentation. I'm going to make you a little tiny in the corner, and I'd love for you to give us a little bit of a background. We know where you are, but tell us what you're doing right now, and then take it away. The floor is going to be yours, and thank you so much for being here with us today.
Excellent. Thank you. It's always good to be with the VETgirl team. So thanks. I get both Garrett and Justine together. Like, how it couldn't be any better than that. So thank you guys. And I am a board certified anesthesiologist, and I have roles in both private practice and academia. So hopefully these tips that we talk about today are useful to everyone. And I am, my most exciting thing at the moment, I am president-elect of the International Veterinary Academy of Pain Management. So that really makes me very, very happy. And hello, Garrett said there's some people saying hello to me. Hello back. Always good to see former students and friends and colleagues. I'm glad you guys could join us. And I want to thank Elanco, as Garrett did, for sponsoring this. And disclosure, we're going to talk about some Elanco drugs today. But we're talking about the Elanco drugs today because they are unique in this long duration that we need to talk about to fill a gap that we have in pain management. You guys know the gap, and we'll focus on that gap. So long duration drugs. Let's start with this case. As you can see, there's our sweet little Luna who's almost healthy. Everyone can see a little ocular nasal discharge, right? But healthy otherwise. Unfortunately for her, she was playing with her little skitter mouse right underneath her owner's feet, and he wears some big heavy boots and accidentally stepped on her, and then she tried to pull her paw away, and she's got a couple lacerations and some fractured metacarpal. So we're going for surgical repair. Let's make an analgesic protocol that we'll look at in the next slide. And what we see in this slide is the drugs or drug classes that we have for treatment and prevention of acute pain. Not a very big list, is it? And just look at that. That's really not very many drugs or drug classes. And so we need to talk about how can we use these few drugs that we have and make them better? How do we use them to maximize their analgesic impact? So let's look at that in the next slide. And this is the path. Remember, the title is Following the Path. Not a lovely garden path, obviously, but the pain pathway and looking at where drugs work. And let's look at the next slide where we can really focus on the drugs that we just talked about, the drugs and drug classes, right? So what we see now a little bit more graphically, I don't know about you guys, but I like pictures better than a slide with a lot of words. We see with the pain starting out in the periphery, that blue dot, that's the NSAID drug class. And we want those NSAIDs on board because, of course, they are anti-inflammatory. And most of the pain, most surgical pain, will be pain of inflammation. Not all of it, right? Because there are changes in the pain pathway. So we want our other drugs on board as well. So that next dot is the local anesthetics, the purple dot, and it's on a peripheral nerve. And remember, local anesthetics block that pain impulse from getting to the central nervous system. That is a very, very powerful mechanism of action. And then our final big dot, the big dots are the most powerful drug classes, right? So our final big dots are the green ones, the opioids, and the opioids work in the spinal cord and in the brain. So those are our three most powerful drug classes. And then we can add in other things like the alpha-2 agonists or ketamine. And so those were the smaller dots working at the spinal cord and somewhat in the brain. And of course, maybe there are a few other drugs or drug categories that we could put in there, but still not very many, right? And none as powerful as the opioids, the NSAIDs, and the locals. And what we want to do now with that knowledge is build our balanced, comprehensive analgesic plan. And we know that we need to utilize these drugs preemptively as often as possible. We're better at preventing pain than treating pain, right? Once pain is started, it's harder to treat. So we want our preemptive analgesia. We want our multimodal analgesia, which is what we looked at in the previous slide, using all of those drug classes. So we maximize analgesic efficacy. And then finally at the bottom, this is really important. We don't want to quit, right? If we have this great analgesic protocol, but we don't utilize our drugs for the duration of pain, we have a gap. So let's look at the next slide. Logistically, how do we use those drugs then? So we divide anesthesia into 4 phases, and we can divide analgesia in those same 4 phases. And this is when we would utilize our drug classes, right? So if we're building our protocol to actually use on the patient, we'll start with anti-inflammatories if we can, right? Preventing that inflammation, maybe some opioids, alpha-2 agonists. Induction isn't a time that we commonly think about pain management, but obviously there's some options, as you see there. Maintenance phase, right? Really focused on pain management. Opioids, alpha-2s as boluses or infusions, lidocaine as an infusion, ketamine maybe, local blocks, right? Really a focus. Post-op, we're okay as long as the patient's in the hospital often, right? We might repeat those drugs, the alpha-2s or the opioids, maybe give an NSAID if we didn't start with one. And we need to prepare for discharge. So let's look at the next slide and talk about this recovery discharge period. What we know from human medicine is that the intensity and duration of pain in recovery and in that early discharge phase are predictive of the development of chronic pain. Now, this is humans, right? But the pain pathway is the same or almost the same. So if this is true of humans, we can scientifically say this is also true of animals. So we really need to control that recovery and immediate post-operative, post-discharge pain to help prevent the development of chronic pain. Now that's crazy, right? Because our discussion is about acute pain, but it can also be about chronic pain if we don't control that acute pain. So we really need to focus on this, the recovery and discharge period and preventing pain. So let's go to the next slide. And we know that with uncomplicated wounds, that inflammatory phase of pain is about 72 hours. Now, with things that are more complicated, like Luna's injury, it's going to be more than 72 hours. And of course, we've already said that inflammation is not the only source of pain. But what we do know is we need to treat pain for at least 72 hours, right, to really get that pain under control. So let's look at the next slide. How do we do that? What do we send home with our patients? So we've already said anti-inflammatory drugs, so that's great. We're going to start there. Maybe opioids, right? But if we send them home for oral administration or even oral transmucosal, we know that the bioavailability is not great, and we're not sending home injectable opioids, and even sending home any opioids can be problematic. Gabapentin is really not great for acute pain, is it? That's not the right mechanism of action. This is pain of inflammation, some direct nerve injuries from the surgery. So gabapentin, probably not great. Tramadol, we used to send it home all the time, and now we know it's not that great either, not that potent, especially in dogs. Cats hate it, so not easy to give to a cat. So what do we send home? let's go back to Luna and let's look at her, what we might do for her. So let's look at a protocol. We'll sort of build an analgesic protocol. We would probably start with an NSAID and an opioid, maybe buprenorphine, maybe something more potent like methadone or morphine or hydromorphone, and an alpha-2 agonist. Nothing in induction. Then definitely going to do a peripheral nerve block with bupivacaine. And we could give her more opioid and alpha-2 to rescue her if we need to in that recovery period, and then send her home with NSAIDs and maybe some buccal or oral transmucosal buprenorphine. Okay, pretty common protocol, right? Look at the timing. So NSAID 24 hours, yay, so that's good. So we've got our 24 hours on board, but look at everything else. Buprenorphine, maybe 6 hours, usually closer to 4 for immediately post-op. The bupivacaine, about 4 hours. Let's say we rescue her in recovery, so we give her another 4 hours, but pretend her surgery finished at 2 p.m., and we rescue her in recovery, so at 6 p.m. then that drug is going to wear off probably. And then maybe the owner gives some oral transmucosal buprenorphine. That might get her till like 10 p.m. Now what? Right at 10 p.m. now, she has no drugs on board except the NSAID, which is probably not potent enough. So let's look at a summary of what we just talked about, at the timing and the duration for the kitty. The NSAIDs, hopefully the owner is giving the NSAIDs, and they are once a day, so at least that's doable for most owners. But the oral transmucosal buprenorphine really should be at least twice, and quite frankly, probably more often, especially with an injury like Luna's. And that can be very hard for the owners to do. So I don't know about you guys, but sometimes I wonder, when we send cats home with drugs, are they really getting any drugs? I mean, hopefully, again, the NSAID, but even that can be difficult for some owners. Not throwing any owner under the bus, right? But I own cats too. I know how hard they can be to medicate. So let's build a different protocol. Now we'll go to the next protocol. We're going to change things up just a little bit. So we're still starting with our NSAID, but now we have transdermal buprenorphine. What is that? We'll be back. And still have our alpha-2 agonist. Nothing in induction again. For maintenance, let's switch out that bupivacaine for liposome encapsulated bupivacaine. And then now let's look at recovery. Again, we could rescue her if we needed to with opioids or alpha-2s. Definitely sending her home with NSAIDs. We're also sending her home with transdermal buprenorphine and intraoperative bupivacaine. How does that work? Well, let's go ahead and summarize on the next slide about timing. And you see now we have the 24-hour NSAID, 4-day transdermal buprenorphine, 4 days, liposome encapsulated bupivacaine, 72 hours. And so you can see now why I'm saying we're sending that home with the cat. The cat is discharged with the NSAIDs and then the buprenorphine and the local anesthetic, but they're already in the cat. Yeah? So the owner doesn't have to give those. So let's look at the next slide and talk about how amazing that is. Decreased caregiver burden. And anyone who has cats or has to medicate cats know that immediately they hide under the bed and you never see them again. And that's really not good for human-animal bond. So preserved, only 1 pill once a day. No control drugs sent home, which takes a load off of our minds, right? And the drugs that are sent home in the cat are FDA approved. So we have the research to show they're effective and the research to show they're safe. So let's look at the next slide. What does that mean? Cats get their meds and they're happy cats, right? So there we have the dancing cat. Okay, which drugs are we talking about? The drugs on this slide. And again, these are the Elanco drugs that are unique in their category. At the upper left-hand corner, we have the transdermal buprenorphine that we just mentioned. That's called Zorbium. In the middle, we have the liposome encapsulated bupivacaine, which is Nocita. And then in the upper right-hand corner, Onsior or robenacoxib, our NSAID. So we have our 3 most potent drug classes with longer duration. Let's look at them in a little more detail. So we'll start in the next slide with Zorbium. And again, it is buprenorphine. So we all know and love buprenorphine. With this transdermal delivery, that's what gives it the 4-day duration. Pretty amazing, isn't it, right? 4 days. It is a class 3 drug. So we are sending home a controlled drug, but we're sending it home in the cat, right? So we're not having the owner administer this medication. So on the next slide is a little bit more about Zorbium. You see that we don't have to shave the hair at all. Just part the hair, put the tube right down next to the skin, squeeze the tube. The transdermal buprenorphine then absorbs through the skin. Within 30 minutes, it's dry, right? So for 30 minutes, don't pet that area where you just put the Zorbium. But within 30 minutes, definitely can pet the cat. Look at the red box in the lower right-hand corner. It is an opioid absorbed through the skin. So we want to keep ourselves safe, right? So no contact with the Zorbium, wear gloves and other protection so you don't get the opioid on your skin. And you see there in the middle, it provides analgesia within 1 to 2 hours of administration. And that's really pretty expected, right? Buprenorphine is not our fastest opioid, and transdermal administration is not our fastest uptake. But that time frame, then you just build that into the timing of administration of this drug. Okay, and on the next slide, remember that Nocita provides 72 hours of pain relief. And so it was approved in dogs in 2016 for tissue injection and approved in cats in 2018 for peripheral nerve blocks. And again, that's 72 hours of blockade of the pain impulses. And that is so powerful. And then finally on the third slide is our robenacoxib, our Onsior. So 24-hour duration. And this one is the only NSAID that is licensed in the US for more than one administration to the cat. So we get a total of 3 doses to administer. I personally like to give the injectable in the hospital and then send home the 2 tablets with the owner. Now let's look in this slide. Pretend that you didn't want to start with the Zorbium in this cat. Maybe you thought she was going to be fairly painful. We could certainly start with a more potent opioid. And how then would you time the Zorbium? Just think about the duration of action of your more potent opioid and then the time to onset of Zorbium, right? I said we needed to build that into our protocol and be sure that you give the Zorbium before the other drugs wear off. There might be some interaction with the opioid receptors between the 2 opioids for a short period, but it's better to have some interaction than have a gap with no analgesia. So just get your timing squared away. So let's go ahead and go to the next slide, and we're just going to summarize everything that we just learned. Think about that pain pathway and following that path with the longer duration drugs, because we know we have this gap. So on the next slide, just a review of what we can do to not have that gap, to decrease or eliminate that gap of the patient being in the hospital, because we have a lot of choices. As long as they're in the hospital, we can continue to give opioid injections, we could give CRIs, right? It's that timing from when they leave the hospital in recovery, and then that early discharge period where they're probably still painful enough that NSAIDs alone are not enough. So adding in these drugs that we can send home with the cat, the local anesthetics, the opioids, the owner gives the NSAIDs, we have our 3 most powerful drug classes. And just the final review, we can see we've got our preemptive analgesia on board, our multimodal analgesia on board, and now we have this plan to not quit the cat, to provide that pain relief in that period where we know if we don't treat acute pain, that's bad enough, but it can lead to development of chronic pain. And again, we know that because the mammalian pain pathway is almost the same from humans to our patients, and we know that scientifically is true in humans, so scientifically true in animals. But now you have 3 tools to provide this longer duration analgesia. And I think we are finished. I want to thank Elanco again. And we have time now to hear from all of you guys. So I hope I left you enough time to ask some questions.
Awesome. Fantastic job, Dr. Grubb. Always love learning with you. Love hearing you lecture. And obviously, we all care about pain. I will also say after I had my C-section, I was so much more empathetic about the importance of multimodal pain therapy. NSAIDs, Tylenol, opioids, everything. So obviously don't use Tylenol in dogs, but dogs and cats. But all right, so let's answer a couple of questions. Love multimodal therapy. Love these new updates out there. And again, just wanted to give a huge thank you to Elanco for sponsoring today's YouTube live event. That really allows us to be able to offer this CE free to you guys. I know you guys are all super busy. Maybe it's coffee break time, maybe it's lunch break time, but in real life, we know we don't get any breaks. All right. So, first question that I'm seeing, do you ever use NSAIDs pre-anesthesia, and do you worry about bleeding? And then we're seeing one comment, NSAIDs don't work with pain. They're not very effective. Do you mind just weighing in on that?
Yeah, what was the second one? NSAIDs don't work.
Do NSAIDs work? Are they effective for pain management?
Oh, two very good questions. Excuse me. Yes, NSAIDs are very effective for pain management, especially acute pain, because so much of it is pain of inflammation. And actually, it's a brilliant way to control pain, because if we start controlling pain at its source, meaning the inflammation, that really decreases the overall sensation of pain, right? We're taking away the pain and the cause of the pain, the inflammation. So yes, they work. I can understand the question maybe if you're talking about some types of chronic pain, like some of the neuropathic pain syndromes where it's not a high degree of inflammation. So yes, they work. And yes, I prefer to give them preoperatively when possible, because preemptive, they're more effective. The good thing about, you ask about bleeding, the NSAIDs that are FDA approved in the US, and I'm assuming similar approval processes in your country, if they are approved for surgical pain relief, bleeding has been tested, right? So the serum chemistry, CBC, and clotting times and platelet function, right, has been tested. So I'm very confident that the drugs that are approved, like the robidocoxib in the cat, the Onsior, would not contribute to bleeding.
Wonderful. I love seeing new options for our feline patients. I will also say, after I brought my 18-year-old cat home and it was post-op dentistry, my husband, who's not a vet, said, "Oh, he looks so miserable. Like you're syringing him buprenorphine orally, and he just looks so miserable." So it's so nice to have a new option where owners don't have to give liquid.
Yeah.
Anything that we need to know about when it comes to us as veterinary professionals administering the long-acting buprenorphine? Like, do we have to wear PPE? Like, what do we have to do?
We absolutely should do whatever it takes to make sure that our skin doesn't come in contact with the buprenorphine. And Elanco does recommend full PPE. At the very least, I would say some gloves, so that as you're parting the hair and putting the tube onto the skin, if you happen to squeeze exuberantly or something and get some on your fingers, right, we don't want to do that. So I would make sure it just didn't come in contact with my skin. If it does, go wash it off right away. But we got to take care of ourselves first.
Wonderful. All right. And since buprenorphine is a partial agonist, how does it impact anesthesia protocols with morphine or butorphanol? Or are you applying this post-operatively?
Absolutely can do it either way. So if you put it on preoperatively, just remember it takes the 1 to 2 hours. And then it's just like the buprenorphine you're already using. So for most of us, buprenorphine is a very common drug. We're very comfortable with it. This is buprenorphine. Everything you know about buprenorphine is Zorbium, right? So no new invention, just longer duration. And then if you prefer to start with something like methadone or hydromorphone, that's also an option if you want some more potent opioids. And then, as we mentioned, that 1 to 2 hour time to onset, be sure you give the Zorbium plenty of time to work before your morphine or hydromorphone wears off. So make sure there's not a gap.
Wonderful. So there's actually another question. I'm glad you mentioned that, the gap in analgesia. One was also, what about the gap with timing of administration of NSAIDs? If you are using a long-acting buprenorphine pre-op and then administering at the end of surgery.
That's definitely an option. I like to give mine preemptively, as I said, but certainly there are reasons to give them post-operatively. As we all know, as long as the patient is normotensive and normovolemic, organs like the kidneys that can auto-perfuse themselves don't really need any help doing that auto-perfusion, right? So When that if that blah, 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 if that patient becomes, I'm so excited to answer this. So if that patient becomes hypovolemic or hypotensive, what happens in those organs is that prostaglandins are activated and they cause vasodilation, and that allows the blood to more easily flow into those organs and deliver oxygen. Right, that's the whole goal. So NSAIDs, unfortunately, are antiprostaglandins, so they can block that autoperfusion response. So if you think the patient might get hypotensive or hypovolemic, or if you're just not comfortable giving preemptive NSAIDs, absolutely you can give them postoperatively. And you're right, you've got your buprenorphine on board, probably an alpha-2 agonist, and your local block, right? So NSAIDs postoperatively are totally fine.
Wonderful. I just see a really funny comment that I'll share when we were talking about administration of Zorbium and PPE. One comment, definitely glove up, and when in doubt, in veterinary medicine, we should always keep our mouth shut. She's referring to anal
I
gland.
love that. Yeah, and that applies to many situations, doesn't it?
Exactly. All right. One more question that I see, and if you have any questions, you have any comments, feel free to type them in. And also, huge shout out to Elanco. So the next time you see your Elanco rep, please make sure to give them a personal thank you for being able to provide this. I also wanted to give a huge thank you to Dr. Grubb, who's been an amazing VETgirl speaker. We always love having her lecture for us because she's clinically relevant and practical, which is our mojo and which we absolutely love. And I did, again, add the link for the survey to document that you've attended this live. So please make sure to fill out that that Google Docs survey. It's going to close in about half an hour, and you want to make sure that you get live interactive CE for half an hour. So again, make sure to fill that out now, especially while we're doing Q&A. All right. One is a question about NOCEDA. Say we have a patient who comes in, they have some type of injury. Is it worth it to have some sedation when that patient is being assessed while waiting for surgery to do a nerve block with the NOCEDA?
Oh, I love the way you're thinking. Whoever asked that. We so underutilize local anesthetics. And this is a classic example. We think about maybe doing it immediately pre-op before we cut, but this patient's already painful. Absolutely, you should be using local blocks as you just described. And so if the patient needs a little bit of sedation, yes, it's worth it, because remember, you're going to sedate it anyway, eventually for surgery. So we can sedate it and re-sedate it once we start the surgery if we need to. But a lot of times they don't react. Bupivacaine doesn't sting like lidocaine does, so they often don't react. But a little sedation or not, please use the local blocks like you just described. It's brilliant. You are brilliant. Thanks for sharing that.
All right. And then last question. A lot of general practitioners may not have naloxone. And if you do feel like you need to reverse an opioid at all, whether or not it's hydromorphone or whether or not it's oxymorphone or it's buprenorphine, what do we do? And if you do have naloxone, can you reverse that buprenorphine?
Ooh, all good questions. So the good thing is most of the time when it's so rare that we need to reverse an opioid, but if we do, remember it's probably going to be the more potent ones like methadone or morphine or hydromorphone. Remember that you can partially reverse them with butorphanol and take away that mu activity. So that takes away the excessive sedation or whatever it was that you didn't like, the reason you wanted to reverse it, without reversing all of the analgesia. So they'll be more conscious, but again, some pain relief. So if I do choose to reverse, that's usually how I do it anyway. I very rarely use naloxone. There isn't a full replacement for naloxone. That's not true. There's naltrexone, which is also a reversal agent, very uncommon for us in veterinary medicine. Buprenorphine is very, very hard to reverse because it binds very tightly to those opioid receptors, which is what gives it that longer duration. It's also responsible for the slow onset because it takes time for that binding. So with naloxone, you can usually reverse some of it if you need to. But honestly, with buprenorphine, I can't remember the last time or if I've ever reversed buprenorphine.
Wonderful. Well, thank you so much, Dr. Grubb. Always love when you share your expertise in analgesia and anesthesia. And thank all of you guys. I know it's 2.5 years post-COVID, but it's been super crazy in the veterinary world. And I know everyone's really exhausted and burnt out. And just taking the half hour when you could be walking outside or shoving down food. We really appreciate that you guys are always willing to learn and love that you guys love to learn. And with that, again, a huge thank you to Elenco, and we will see you at the next event. When in doubt, check our website for great opportunities to be able to learn a bunch of free sponsored content too. And we will hopefully see you at the next event or live in person at VETgirl U in August. Take care, everyone. Thank you.
Have a great day, everyone.